So I've just finished my general survey of my patient. I've performed hand hygiene again. All of my equipment is sterilized. I've maintained my patient's privacy and dignity. The curtain's drawn if there was one. The door is shut. There's no one else in the room. Is it okay if I perform a vital signs assessment on you? I'm going to check your pulse, your respiration rate, and your blood pressure. Okay, perfect. I'm going to start by palpating. When you use your right arm, okay? Only using, and if this were a long sleeve shirt or a gown, or I would just only expose the area that I'm assessing at that moment to maintain dignity the whole time. I'm going to palpate the radial pulse with 3 fingers. Listen for 30 seconds as long as it stays within normal range of 60 to 100 beats per minute. Got about 35 beats in 30 seconds, so that's going to be 70 beats per minute pulse rate rather, which is within normal range of 60 to 100. So I don't need to do it for the entire duration of 60 seconds. I like to transition from pulse right to respiration. So while I'm doing this and without saying, I'm just going to have the patient place the hand I'm holding onto her chest. Can you place the hand onto your chest for me? Thank you. And then I'm going to switch hands, same 3 fingers on the radial, and I'm going to stand to the side of my patient so that I can see how my patient's breathing. I can see from this angle, I get a good idea of the chest rise and the chest fall. I'm able to actually feel her chest rise and fall from the placement of her hand, since my hand is assessing her radial pulse. And from here, I'm going to watch a full chest rise, full inhalation, a full chest fall, full expiration, which equals 1 respiration for 30 seconds. And as long as it's within normal range of 12 to 20 respirations per minute, I won't do it for the extended period of 60 seconds. So I got about 7 full respirations, full inhale and full exhale. You can put your hand back down for me, thank you. The reason you do this is because if you tell them that you're going to be taking their respiration rate and counting how many breaths they have per minute, they're likely to actually change their respiratory rate. So you kind of want to do it in a sneaky way so that you don't let them know you're actually taking their respiration rate. That's why I like to transition straight from pulse to respirations. So you had a 14, which is normal. It's in between 12 and 20, which is normal. So I do not need to do it for 60 seconds. If I'm going to auscultate, my equipment is clean and sterilized. And I've already performed hand hygiene. Maintaining patient dignity. Are you comfortable and warm? Perfect, okay. For auscultating the pulse, I would usually use the same with respirations. I could listen to her heart rate through her chest wall, as well as her quality of breathing, if she is labored breathing, or I can get a good accurate pulse rate and respiration rate through auscultation of the chest. I usually like to pick a spot right near the sternum, kind of near the aortic valve, the second intercostal space. And I would do the same here. Listen for 30 seconds. And I would do that for both respiration and pulse if I wanted to auscultate for either. if for some reason I couldn't get a good reading through palpation. Another way to palpate for respiration is you can put your hand lightly on the patient's back, kind of like in between the scapulas, right on the vertebra. Depending on how the patient's behaving, if they're irritable and angry or don't like being any kind of physical contact, this probably isn't a good option. So it's a case-by-case basis. Kind of need to approach every assessment you do on an individualized basis with each patient. Other pulses you could get are the brachial artery. We did radial, you can do the brachial, you can do the carotid artery, you can do the popliteal behind the knee, you can do the posterior tibialis, or the dorsal pedal pulse on the lower extremities. Ideally, radial is the easiest and most convenient for you and the patient. Is it okay if I take your blood pressure?
Mm-hmm.
Perfect, okay. My equipment is clean and sterilized. I told my patient what I'm about to do. I want to make sure it's deflated before you put it on. Do you prefer an arm? Is your right arm okay? Perfect. Some patients have limb alert wristbands, and I don't see any of those on my patient. Make sure it's like at least an inch above the crook of the wrist there. Make sure sizing a blood pressure cuff is very important. You don't want it too tight or too snug. If it's too large or too small, you'll either upset your patient, and either way you're going to get an inaccurate blood pressure reading. So sizing the cuff for the patient is very, very important. So first thing I'm going to do is I'm going to palpate for a blood pressure. Normal blood pressure is 120 for the systolic over 80, which is the diastolic. I'm going to make sure that the pump is closed, because if I try to pump it and it's open, then I'm not going to get anywhere. The cuff's not going to fill up. So I'm going to try getting a two-step blood pressure. The first step is to palpate the brachial artery for a blood pressure. Again, I'm going to use 3 fingers, and it's medial side of the arm, kind of right above the crook of the wrist, like right under the, I kind of describe it as going right under the bicep. Luckily she has a strong pulse, so I'm going to pump up until I do not feel the pulse anymore, and that'll be my starting point. So I'm going to keep a close eye on the dial here and make sure that I stop the second I don't feel her brachial pulse anymore. So it's at 110. So I'm going to deflate completely. Is that uncomfortable at all? Another good way to know if it's not too tight or anything, you can fit 2 fingers under there. It's not too snug, but it's not too loose. So we got a reading of 110 through palpation. So when I go to auscultate this time, the second step of the 2-step process, I'm going to use the diaphragm. I'm going to pump up 30 milligrams of mercury over the 110. So I'm going to pump up to 140 milligrams of mercury and then deflate 2 milligrams of mercury per second until I hear the first lub, which is the S1. And that'll be my systolic pressure, and then I'll keep slowly deflating 2 milligrams of mercury per second until I hear the last dub, which is the diastolic. Okay, you ready? All right. And make sure your thing's closed. I'm going to fill up to, again, I said 30 milligrams over what I got last time, which was 110, so that'll be 140. Just there. Then deflate 2 milligrams of mercury per second. So I heard the first S1 at systolic at about 112. So I heard her systolic at 112 and her diastolic was about 78. So 112 over 78, which sounds a little low, but it's nothing too, it's not pre-hypertensive or anything. Do you tend to run a little low? A little bit? Okay, so that's normal for my patient. Again, I deflate completely, remove the cuff, clean all of my equipment again, sterilize it for the next time I need to use it. Other places that I can use the blood pressure cuff or a cuff to get a manual pressure of some kind would be, I could use the forearm to get a blood pressure through the radial pulse. I could use a larger cuff. Of course, this is where size of blood pressure cuffs is so important for over the leg to get the popliteal artery, and you can also go to the lower, even lower on the extremities to get the posterior tibialis. So those are other locations that you can take it. Do you have any other questions? Perfect, okay.
Thank you.
You did great, thank you.
You too.